My name is Katherine Salvador. I think most of you know me by Katie. I'm a PA here at the Root Center, and I work providing mental health and medication-assisted treatment to our patients here. I started here in 2018. Before I started working here, I also worked in Massachusetts providing MAT and mental health to patients. And I also worked in an inpatient consult service in a hospital. So I'm hoping to share a little bit of wisdom with you guys about medication-assisted treatment and how to match each patient with the treatment that's best for them. Here at the Root Center, we recently expanded our services just about a year ago to include MAT other than methadone. We now have patients on Suboxone, Vivitrol, Sublocade, and other anti-craving medications for things even outside of opioid use disorder. We have some patients who are only here for treatment for alcohol use disorder. So today during the presentation, I'm going to review a topic that I think is a little bit challenging. And like I said, that is matching the right patient with the right treatment for them. So when did addiction even become a medical thing? It's actually pretty recent. Even just 10 years ago, outside of methadone maintenance, people looking for help for addictions, for alcohol, cocaine, opiates, they did not necessarily think to themselves, I'm going to go to my doctor. That's fairly new. People were told to go to AA, go to groups, go to NA, maybe see a therapist, a shrink, maybe be whisked away in a van to a rehab center in Florida. The idea that you could go to your primary care doctor or talk to one of your medical doctors about your addiction is something that's really been popularized in the last 5 to 10 years. This article here was published in 1997 in Science magazine. So think about how recent that is, 1997. And this headline here, "Addiction is a brain disease and it matters," was kind of a new thing. This really took people by surprise because for so long, people thought about addiction as being poor character, bad morals, maybe bad parenting, personality deficits. Maybe people are selfish. Maybe they have a lack of willpower. And we even still hear those things today. We're still battling the stigma of addiction, even in the medical field within our own peers. When I was in PA school just 7, 8 years ago, addiction was not part of my curriculum at all. I graduated without knowing what Suboxone was or what methadone was or how they worked. That has all changed in the past 5, 10 years or so. Most medical schools and PA schools have to involve addiction in their curriculum. And there's even a fellowship now for medical doctors, for internists who would like to specialize in this field. So we have come a long way. So what happened? What sparked us to make all these changes? Unfortunately, it really started because Americans started dying, and they were dying at alarming rates. Addiction became a public health crisis. The increases in overdose deaths over the past few years have been so steep that they've contributed to reductions in the country's life expectancy, which is something that hasn't happened since World War II. Drug overdoses are now the leading cause of death for adults under the age of 55. In 2017, drug overdoses killed more than 70,000 Americans, which was a record. Overdose deaths are now higher than deaths from HIV, car crashes, and gun violence at their peaks in this country. And the data show that that steeply correlates with the use of synthetic opioids like fentanyl. You can see this very steep incline just since 2013. In 2018, the number of drug overdose deaths decreased by 4%, but the number of drug overdose deaths was still 4 times higher than in 1999. And in 2019, you can see in this chart, we went back up again to over 70,000 overdose deaths. How this happened is for a different lecture. There's a lot of different theories about that. Basically, in the late 1990s, pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers. So healthcare providers started prescribing them at greater rates. And that's not the only thing that happened. But like I said, that's a topic for another lecture. So you guys, I'm pretty sure everyone on this in this lecture has been working in the field. You've seen the billboards, you've seen the commercials, you heard everything on the radio. Our country is battling an opioid overdose epidemic right now. So before I go into matching the right patient to the right MAT, I want to talk for a second about why MAT matters. And it's really based along the concept that addiction is a disease and it should be treated as such. So every year I give a lecture to the Springfield College PA students about addiction and MAT, and I really try to drive a point home with them that people who are coming to their office or to their emergency rooms are just as deserving as of medical treatment in a compassionate and knowledgeable way as anybody else coming to them for any other disease, diabetes, high blood pressure, or emergency diseases. And every time I go through these slides, it gets me fired up, and I really wanted to share it with you because I think it would remind everyone to practice with a little bit more empathy. Okay, so I'll try to go through it as quickly as I can, but let's start with the disease of addiction. Won't go too much into the anatomy, just briefly touch on it. This is the reward circuit of the brain, the nucleus accumbens, the prefrontal cortex, and the ventral tegmental area. This is also called the pleasure center of the brain. So this part of the brain is one of the most ancient, most primitive parts of our brain. It is so deeply ingrained into our core, and it is wrapped up in our survival. This is what tells us every day. We don't even realize it now, but this is what tells us every day. And this is what told our ancestors every day to get up, to find food, to find water, and to find a mate so that they could survive. Basically, this pathway gives us positive reinforcement when we do those things. When it's activated by a rewarding stimulus, which could be food, water, sex, information travels from the VTA to the nucleus accumbens and then up to the prefrontal cortex. So what is that reward that our brain gives us when we do those things? It is dopamine. This circuit has been really useful. As a species, we would not have been able to survive without it. It's what drives us to do those things. Every time we drink water, eat food, have sex, we get a release of dopamine in our brains, and it's reinforcing for us to tell us to keep doing that so that our species can continue to survive. It is really useful when it's applied to those things, but unfortunately, when it's applied to addiction, it's a lot less useful, and it makes addiction really, really difficult to treat because, like I said, it is so wrapped up in that most ancient, primitive core of our brains. So let's talk about dopamine and serotonin just pretty quickly. These are two neurotransmitters in your brain. They make you feel good. Serotonin, we talk a lot more with psychiatry. Serotonin is low in anxiety and depression. It modulates mood, memory, cognition, and sleep. I'm sure you've all heard of SSRIs. Those work on increasing serotonin in the brain. Dopamine, this is the chemical that reacts with the reward center we were just talking about. It gives us a great sense of euphoria, pleasure, and reward. But if you notice the two behaviors that are associated there, compulsion and perseveration, it was really, really helpful for our ancestors to wake up in the morning and be compulsive about finding food and finding water, to perseverate on it. That makes total sense. But when you apply those behaviors to the disease of addiction, you can kind of start to see why people cannot stop thinking about obtaining the drug or alcohol or whatever substance it is that they're addicted to. This is just kind of an interesting tidbit that I wanted to include. The reward circuit interacts with the hippocampus and the amygdala. The hippocampus and the amygdala modulate memory and emotion. So they're part of the cycle of relapse. Feeling sadness, frustration, feeling overwhelmed, all of these things can trigger drug use or relapse, as does being around familiar places, people, or things. For example, I have a patient who associates the smell of McDonald's French fries with using drugs because he used to use in the McDonald's bathroom, right? So that smell he's associating with using, and that's all because it's so caught up in this whole system. And triggers like that can happen 100 times a day for people who are addicted to a substance. Again, why it makes this disease so difficult to treat. So just to give you an idea of baseline dopamine levels, On average, most of us are sitting at dopamine levels of like 100 units. Some of us are a little higher, some of us are a little lower. When I think of someone who is maybe a little bit higher, I think of Leslie Knope from the TV show Parks and Recreation. Not sure if anybody watches that, but she is bubbly, positive, full of energy. These are some direct quotes from her on the show. She's probably sitting at a dopamine level of maybe close to 110 units. And then we have people who are naturally a little lower than 100 units. And I like to call these people kind of like the Eeyore type. And here's another example from a TV show of Stanley from The Office. He's probably sitting at dopamine levels maybe around 90. He's kind of low energy, not very motivated, just kind of has a negative outlook. So he's probably a little less than 100. This is a chart that shows how your dopamine spikes and how high it can spike with different substances. So baseline, if you're at 100, if you have a really good piece of chocolate cake or your favorite food, maybe you can get to a dopamine level of 150. Sex can get you to 200. Cocaine, 350. If you look at methamphetamine, it's all the way up there at 1250. And heroin and opiates are not shown on this chart, but they can get you to about 500 to 700 units of dopamine, depending on their purity. So just briefly touching on how drugs work on the brain. Basically, all drugs work to increase dopamine, like we just talked about. Every drug is working somewhere in the dopamine production line. It either increases the dopamine, increases the receptors welcoming the dopamine, or it creates fewer vacuums that suck the dopamine out of the cell. Consequently, you can get to a level of 350 dopamine in the brain after using cocaine. Heroin is a little bit more complicated. It attaches to the mu opioid receptor and basically results in the production of more dopamine in the brain. But again, every drug or addictive behavior alters the amount of dopamine your brain is seeing. So once your brain starts seeing consistent levels of dopamine that are very high, over 300 units, it starts freaking out a little bit. It sounds the alarms. It says, this is not right. This is not the level of dopamine that I should have. I should be somewhere around 100. And it starts making a plan to fix that problem. It starts to downregulate. Basically, the brain will stop making its own dopamine. It will get rid of the receptors welcoming dopamine and will increase the number of vacuums that suck dopamine out of the cleft. This really results in a broken brain. With all of that downregulation, the new baseline dopamine level for a person who is addicted to a substance is incredibly low. Most people suffering from addiction are sitting at a new baseline of about 30 to 40 units of dopamine. It is profoundly difficult to function at this level of dopamine. It's hard to get out of bed. It's hard to go to work. It's hard to care for your children, to maintain any sort of relationships. Really difficult to survive at these levels of dopamine. I'm sure you guys have all heard the term chasing the high. This is kind of what's meant by that. So when people first use drugs or alcohol for the first time, they can kind of feel that feeling of feeling high. The dopamine can spike really high in the brain. But after months of consistent use, they'll never be able to get back to that. They're just using to get back to their normal baseline dopamine level. And I'm sure you guys have all heard that from our patients who say, I'm just using to feel normal. I don't even get high anymore. I'm just using to feel normal. They're sitting so low at their baseline dopamine level of 30, 40 units, and then they're using heroin just to get back to somewhere around 100. They now have to use just to feel normal and to be able to function. And that is not even taking into account withdrawal symptoms. So on top of feeling like absolute crap from having a dopamine level of 40, our patients wake up in the morning feeling sick and withdrawal with flu-like symptoms, right? Like vomiting, diarrhea, restlessness. So what I tell the PA students when I give this lecture is that no, most people suffering from addiction might not be their most friendly, cooperative patients in their waiting room. But I thought that this whole spiel kind of reminds people to practice with a little bit of compassion and empathy. So I hope you guys are able to take something out of that. You can spend all day Googling PET scans on the internet that show the brains of different people suffering from different addictions. You can literally see a change in the brain chemistry. The brain on the right has almost no red, which is dopamine. So how can anyone really argue that this is not a diseased brain, that this is not a medical problem? Again, here are more pictures. Some of these pictures show alcohol, and that works a little bit differently. It works on a different pathway. So this is really what is meant when we say that addiction is not a choice, it's a disease. We're talking about these actual changes in brain chemistry that occur when somebody consistently uses a substance over time. It makes it nearly impossible for them to wake up in the morning and just choose to not use drugs and just choose to not use alcohol. I think a lot of people who misinterpret that statement think that we're saying that it's the initial choice. They made the initial choice to be at a party and try cocaine, or they made the initial choice to try alcohol. But that's a misinterpretation. And honestly, we can argue that too, because why do people use drugs and alcohol or other substances in the first place? I think most of us know it's usually to escape some sort of pain, physical, emotional, abuse, trauma, neglect. So really, who are we to judge? And I always give this example to the PA students because they have studied medical conditions like diabetes. And there are a lot of similarities. Name any disease and you'll have receptors and transmitters that have failed and messaging systems that have gone awry. So let's take diabetes, for example. In a healthy person, the pancreas makes insulin. Insulin goes to the insulin receptors and it tells the body to suck glucose out of the bloodstream. And type 1, there's not enough insulin being made by the pancreas, just like the brain not making enough dopamine, right? And type 2, insulin is being made, but the receptors are broken. So glucose is just hanging out in the bloodstream, just like when the dopamine receptors are turned off when the brain is downregulating an addiction. So this pathway looks a lot like the reward system in the brain. And nobody argues that type 2 diabetes is not a disease, even though many people who have type 2 diabetes would not have it if it weren't for the lifestyle choices that they made. I'd like to give this example of 2 different patients who might come into the emergency room. On the top left corner, we have Carl. Sorry. Carl is obese. He eats donuts and fast food every day. Even though he is diabetic and his PCP has outlined specific nutrition recommendations, he does not follow them. He's non-compliant with his medication, so his blood pressure is really out of control. So is his cholesterol. He does not partake in any physical activity. His father passed away from a heart attack at age 51, so he knew his genes. Carl gets admitted to the hospital with chest pain. He has a heart attack. He gets top of the line medical care without stigma, despite a lot of the lifestyle choices that he made that have undoubtedly contributed to this condition. He's hospitalized for 5 days. He goes to cardiac rehab. He started on new medications. He's referred to a nutritionist, a cardiologist, a PCP, even a therapist. On the bottom right, we have Karen. Karen had a difficult childhood. She suffered emotional and physical abuse. She was diagnosed with major depressive disorder as a teenager. She started using opioids at age 17 and heroin at age 20. Karen suffered an overdose at home and was given Narcan by EMS and brought to the emergency room. Sorry. She was monitored in the emergency room for several hours. They tried to find her a bed at a detox facility, but no beds were available. She was sent home with a piece of paper with some phone numbers on it. The 30, 60, and 90-day mortality rates are higher for Karen. So in the medical field, we've come a really long way, but we still have a long way to go. This slide just kind of points out that since addiction is now considered a disease and we're treating it as a disease, we should be talking with medical jargon. And the DSM-5 kind of outlined that we shouldn't be using terms like abuse anymore. Has a negative connotation to it, right? Sounds much more medical to say someone uses alcohol use disorder, someone uses opiates, they have an opioid use disorder, than to say they're an abuser of a substance. Same thing with the terms dirty and clean. Someone's urine shouldn't be dirty. That has a negative connotation to it. They're not a dirty person. It's just positive for opiates. It's positive for cocaine. Okay, so kind of switching gears, we'll talk a little bit more about treatment. Addiction treatment, as you all know, encompasses a lot of things. Behavioral therapies, recovery support services, medical detoxification services, but today we are going to focus mostly on pharmacological treatments and medications for addiction. The key to the term medically assisted treatment is the word assisted, meaning that medication alone is not an effective treatment for addiction. Instead, the medications are usually combined with behavioral therapies to create a comprehensive approach. In our lecture today, we will be focusing more so on the medications. So MAT has come a long way. In the 1970s, the addiction treatment system was just starting. There were no clinical guidelines. This kind of cultivated a chaotic atmosphere. There's not much evidence on the effectiveness of MAT, no therapeutic dose ranges. And as a result of this, a damaging series of articles came out of Florida entitled Methadone, the Deadly Cure. The series of articles laid the groundwork for much of the stigma that surrounds MAT, even now today. Prior to 2016, very few physicians were licensed to prescribe medications. However, when the Comprehensive Addiction and Recovery Act was passed, nurse practitioners and physician assistants were granted the ability to be prescribers as well. This was further expanded in 2018 with the Substance Use Disorder Prevention that promotes opioid recovery and treatment for Patients and Communities Act. The Support Act expanded the ability of physicians and other qualifying practitioners to treat more patients so they could have a higher number of patients on their caseload. Today, MAT is considered the gold standard for the treatment of opioid use disorders. So there are three main medications available in the United States for the treatment of opioid use disorder. Two opioid agonist medications, and we'll go over what that means, are methadone and buprenorphine. And just so everyone knows, I use the term Suboxone interchangeably with buprenorphine. Basically, we're talking about the same thing when we're talking about those two medications. Buprenorphine is essentially Suboxone. Suboxone is just the brand name. And then we have an opioid antagonist, basically an opioid blocker treatment, and that is naltrexone. Methadone and buprenorphine are controlled substances that are regulated by the DEA. Naltrexone is an FDA-approved treatment for OUD, but it is not a controlled substance, and it's not subject to special regulatory oversight. So I'm going to go through each of these medications because I think understanding them and how they work is essential to being able to refer patients to the treatment that's right for them. So I think we're all familiar with this one, OTP or MMTP, the Methadone Maintenance Treatment Program. It's a comprehensive treatment program that involves daily observed methadone dosing on site in conjunction with individual and group counseling, drug testing, educational groups, and structured activities. It's staffed by medical providers, nurses, social workers, counselors. It provides structure to daily life. Methadone is highly effective for opioid use disorder, and it's been around for more than 40 years. It is FDA approved, obviously. Maintenance of opioid addiction treatment with methadone is approved in conjunction with appropriate social and medical services. It's a full opioid agonist, so that means it's a DEA Schedule II. It's a controlled substance. It is itself an opioid. Therapeutic doses can be fatal for non-tolerant individuals. So somebody who is opioid naive, somebody who has never taken methadone before, if they took one of our patients' doses of 100 milligrams or so, that could be fatal for them. And there is a risk for potential for diversion in the community. Methadone is synthetic, meaning it's man-made, it's long-acting, and it's an agonist. So methadone binds to the opiate receptors in the brain cells, and it produces effects that are similar to other short-acting opioids. When I'm first starting a patient on methadone, I explain to them that it works similarly to other opioids. It has the same response in the brain as heroin, morphine, codeine, but it works a little bit differently because it's very long acting. When it's administered in steady oral doses once a day, the level in the blood should maintain a 24-hour asymptomatic state without episodes of over-medication or withdrawal. So unlike when patients are using heroin or short-acting opiates, Percocet, oxycodone, they're getting a spike in the bloodstream and they're feeling that high and the euphoria, and then hours later they're crashing into withdrawal. That's why methadone's different, because it's long acting. You take it once a day and you should just feel normal. You should just feel like your normal self. There shouldn't be highs and crashes. And that allows patients to stabilize, to get some time under their belt without thinking about using, without those highs and lows, so that they can continue to do that. Some people continue to stay on methadone for the rest of their lives, and some people it's just a short-term thing and they'll start to taper after having that period of stability. But an appropriate dose of methadone will suppress withdrawal symptoms and opioid cravings for 24 to 36 hours, and tolerance should remain steady. So what that means is that when people are using heroin or fentanyl or other opioids, typically they need escalating and escalating and escalating doses in order to feel the same. So people will start using a few bags and they'll escalate up to a few bundles. With methadone, that really shouldn't be the case. Somebody who's taking 100 milligrams should be able to stay on 100 milligrams for years without needing to increase the dose. So methadone's available in various forms: diskettes, tablets, oral solutions, liquid, powders. In the United States, we usually give liquid form and MMTP. Sorry, my throat. There are side effects of methadone. QT prolongation, we've all heard of that one. That's a common problem amongst our patients. Constipation, low testosterone in men, decreased libido or sexual performance, sweating. I know we hear about sweating a lot from our patients. And some people, nausea. When people are ready to come off of methadone, the dose must be tapered gradually and slowly. And there are restrictions to methadone. It may not be prescribed outside of OTPs for the treatment of addiction. So methadone has been studied. Thank you. Emily just brought me water. Sorry, guys. So methadone is really effective. Studies have shown that it reduces mortality, reduces illicit drug use, increases abstinence rates, and improves retention and treatment. It also reduces criminality and legal problems and really allows for return to productive activities in family and work. Methadone can be dispensed only at an outpatient opioid treatment program that's certified by SAMHSA and registered with the DEA, or to a hospitalized patient inside of a hospital. Only legal outpatient treatment using methadone for opioid use disorder is in clinics that are licensed by the state and federal governments. Methadone is not available for office-based treatment. People cannot just go to their doctors and say, "Can you give me a prescription for methadone to help with my opioid addiction?" That is against the law. It's a little bit confusing because methadone can be prescribed in that way for pain, but it cannot be prescribed for opioid addiction. And access to methadone treatment varies widely throughout the United States. So really, access to methadone treatment can be a bit limited by the fact that it cannot be prescribed in an office. That differs a lot from Suboxone, which is what we're going to talk about next. Suboxone can be prescribed in the office setting, and it can be picked up at a pharmacy, and the patient takes it at home. The Data 2000 was federal legislation. It said that in 2000, qualified practitioners can prescribe buprenorphine without the control structure of an opioid treatment program when they meet certain requirements and obtain a waiver. So that means any medical provider, PA, NP, GI doctor, primary care doctor, psychiatrist can prescribe Suboxone to their patients for the treatment of addiction as long as they have a waiver. Suboxone also can be prescribed through opioid treatment programs. It can be dispensed right at the clinic, the same way that methadone is. So the great thing about buprenorphine is that it has expanded the access to treatment. There are fewer restrictions than methadone because of its pharmacology. We'll go over that a little bit. Buprenorphine is a partial opioid agonist, and it's associated with lower overdose risk. However, clinicians must exercise good judgment when determining their treatment plans. An absence of explicit regulations with regard to office visit frequency, urine drug testing, and medication supply does not obviate the need to consider patient safety risks and the potential for the diversion of the medication. Okay, so what is a partial agonist? Basically, it does not activate the opioid receptors fully. In essence, it produces a ceiling effect that prevents larger and larger doses of buprenorphine from producing greater sedating effects or greater agonist effects. So with buprenorphine, we have less sedation, less euphoria, and less risk of overdose. So overall, it's considered a bit of a safer medication than methadone, and that's why we can prescribe it in an office setting. It binds strongly to the receptor and it's long acting. So same as methadone, you can take it once a day and it should last you the full day. It can cause precipitated withdrawal if there are other agonists like heroin, methadone, codeine already on the receptors in the brain. This just is kind of a visual of the difference between an agonist and a partial agonist. An opioid agonist like heroin, methadone, codeine, they fit perfectly right into the receptor and there's a firing response, meaning that it produces those effects of an opioid. Respiratory depression, sedation, euphoria, reward. Partial agonist like Suboxone or Subutex sits in the receptor and kind of blocks the site, but it doesn't produce that full agonist response. It's only a partial response because it doesn't fit perfectly into the receptor. And then we have an opiate antagonist, which is naltrexone. Another name for that is Vivitrol. That does not fit into the receptor at all. It just blocks it. It does not produce any sort of opiate effects or any sort of firing response. It just knocks the other opiates off the site, completely blocks it. So this is just kind of showing with methadone or a full agonist, increasing doses of the medication more and more can lead to increasing respiratory depression, which can lead to overdose. Suboxone is supposed to be a little bit safer in that regards because of the ceiling effect. Increasing doses and increasing doses and increasing doses at some point kind of level off with less respiratory depression. With an antagonist like Vivitrol, you don't have any sort of opiate response. It's just a blocker. So the main thing to understand about Suboxone and its mechanism of action is a term called affinity. It's basically the strength that Suboxone will bind to the opiate receptor in the brain, and that is really strong. So Suboxone binds really tightly into the opiate receptor. And when it does that, it will kick off other things that are on the receptor, like heroin or methadone, and that's what causes precipitated withdrawal. So here's the mu receptor. Suboxone is coming and attaching really tightly. So anything that was already on there, like if somebody had used heroin just recently and it was sitting on this receptor, the Suboxone came in, kicked it off, took its place, and now the patient is in withdrawal from the heroin or the methadone being removed from the receptor. And I think that is best visualized by just a minute-long video that I would like to share with you.
Buprenorphine is an example of a partial opiate agonist. When it binds to the opiate receptor, it stimulates the opiate receptor partially. This is enough to alleviate symptoms of opiate withdrawal and to help with cravings for opiates. When starting an individual on buprenorphine, it is given while a person is in opiate withdrawal. You can visualize this as the opiate receptors in the brain as being empty or open in a withdrawal state. And when buprenorphine is given, it alleviates withdrawal symptoms and helps with cravings for opiates. As the dose of a partial opiate agonist increases, there is a ceiling effect or plateau in terms of respiratory depression, such that further increases in the dose does not result in further respiratory depression. This provides relative safety in terms of overdose risk with a partial agonist compared to a full agonist. The following is a demonstration of precipitated withdrawal. Buprenorphine has a very high affinity for the opiate receptor. If it is given when a full opiate agonist is bound to the opiate receptors, it will displace them. It is this relative difference between full activation of the receptor to partial activation of the opiate receptor that causes precipitated withdrawal. When an individual is on a therapeutic dose of buprenorphine, it provides relative protection against overdose. You can visualize this as most of the opiate receptors in their brain being occupied by buprenorphine. If an individual uses a full opiate agonist, such as heroin, on top of their buprenorphine, the euphoria and the effects of the full opiate agonist, including respiratory depression, are blocked as buprenorphine has a higher affinity to the opiate receptor. This provides relative protection against overdose.
Okay, so I hope that was a little bit helpful. Suboxone can be quite difficult to understand. I think the most important take home is that people who have heroin, methadone, opiates in their system and then want to take Suboxone need to wait at least, we're saying, about 2 days now, especially for fentanyl, before starting Suboxone. But when it's the other way around, if somebody already has Suboxone in their system, if they're taking their dose every day and then they use heroin, they don't get sick. It's just that nothing happens at all. And that's the point of Suboxone. It reinforces abstinence because when somebody uses heroin or another opiate, it will block the effects of it. So it kind of works as a blocker. So buprenorphine has also been proven to be just as effective as moderate doses of methadone for the reduction in drug use and retention in treatment. Buprenorphine's partial agonist effects make it reinforcing, encouraging medication and treatment compliance. I just feel normal, and that's always the goal. With methadone, Suboxone, would be to have the patient on a dose where they just feel normal. So buprenorphine it's available in many different forms. We have the films, tablets, and there's now an injection, which is Sublocade. The combination tablet, basically what Suboxone is a combination of naloxone, which is Narcan, and the buprenorphine that we were just talking about. Now, when Suboxone is used the way that it should be used, which is under the tongue, the naloxone is not available to the body. Your body can't absorb it like that. It doesn't work. The reason that it's in there, the reason that it's in the Suboxone is to try to prevent people from trying to abuse the medication by trying to inject it. If they were to try to inject their Suboxone, the naloxone, the Narcan, would become active and force them into withdrawal to prevent overdose. So it's kind of cool. It's a little bit complex. You'll hear people a lot saying that they can't be on Suboxone because of the Narcan in it. The Narcan is what's making them go into withdrawal. But we found that that's not true. What they're really talking about is what we just went over, with the Suboxone itself having a higher affinity for the receptor. This is Sublocade. We just started doing this here at the Root Center. We have a few patients now on it. Unlike Suboxone, which is under the tongue administration, Sublocade is an injection. It's once a month, and we give it into the area right around the belly button, on the stomach, right under the skin. And the advantages of this is that it increases compliance. Okay. One of the main problems and one of the things we worry about the most with Suboxone is that somebody might choose to not take their medication in the morning because they have the freedom to do that, right? They have the medication at home. They're not coming to the clinic every day for it. So someone could wake up and choose to not take the medication so that they can use heroin and feel it. If they have their injection for the month, that's not a choice for them. So it increases compliance. You don't have to worry that they're going to be putting themselves at risk for relapse. And there's no diversion risk. Again, people don't have a supply of this medication from the pharmacy. It's just a once a month injection. The disadvantages of this injection site reactions, it can cause an unsightly bump in the stomach, can be painful. I think a lot of people think it's worth it to not have to take the Suboxone every day. A lot of people, I'm sure you've heard say that it's disgusting. It has like an orangey taste. So this kind of alleviates that. And this is just a little chart if anybody's interested in going back after the presentation to look at the differences, the main differences between buprenorphine and methadone. And I just want to point out there are more drug interactions with methadone, especially with HIV meds, anticonvulsants, IV medications,
It's a bit chilly.
depressants.
A bit chilly, it's damn cold. You get those?
Naltrexone, let's switch gears a little bit.
Now, because I gotta do your group thing.
Yeah. And then I'm
Opioid antagonist.
Can you guys mute yourself?
So an antagonist, just like we said, completely blocks the receptor, blocks the euphoric effects of opioids. It has a higher affinity to mu-opioid receptors than heroin, morphine, methadone, and even Suboxone. So naltrexone will even kick Suboxone off the receptor and block. When it sits on the receptor, it blocks the effects of other opiates. So this can precipitate withdrawal in patients who have not been abstinent for at least 7 days. So that's why this medication is really challenging. Patients cannot have opiates in their system for 7 to 14 days. I usually say they need to have a negative drug test to start this medication. It has no narcotic effect. It's not a narcotic. There's no withdrawal symptoms, tolerance. There's no abuse potential with this medication, which makes it a great option for some patients. But despite all of these advantages, it's had little impact on addiction treatment in the United States, primarily because of poor patient adherence. There's very high dropout rates. And it may not be as effective in treating opioid cravings as methadone or Suboxone. It's available in a tablet. It's also available in an extended release injectable, which is Vivitrol. Similar to the Sublocade, we give Vivitrol once a month, so the patient doesn't have to think about waking up every morning and taking their dose. As a depot formulation, dosed monthly, Vivitrol obviates the daily need for patients to motivate themselves to stick to a treatment regimen, a formidable task, especially in the face of multiple triggers of craving and relapse. Okay, so matching patient with MAT. Many patients with opioid use disorder would benefit from multiple or all of the different kinds of MAT, methadone, buprenorphine, naltrexone, and you'll commonly hear from patients that they've tried all three. There are certain patient characteristics that can influence your choice of which medication would work for that patient. Definitive evidence for this is lacking, except for in specific examples like pregnancy. So in the absence of evidence.
Can I ask everybody to please mute themselves? We're getting a lot of feedback. Sorry, Katie.
That's okay. So yeah, in the absence of any evidence, good clinical judgment must be exercised in determining each treatment plan. So the first thing I always think of is agonist or antagonist. So we learned that our agonist medications are methadone and Suboxone, and our antagonist medication is Vivitrol. So methadone and Suboxone, for me, really are the two main choices to choose from when you have a patient who's coming in looking for help, who is currently using every day. A full opioid agonist will improve their withdrawal symptoms and help their cravings, and they can start it pretty much right away. The methadone they can start that day. Suboxone they could start in about 2 days. Naltrexone and Vivitrol, it's a little bit of an outsider for me. It will not treat withdrawal symptoms. It will not really lessen cravings. I really like to consider this medication for a certain patient population, patients who have already completed detox, and they already have a negative drug screen, they haven't used recently, patients who are being released from incarceration, who are preparing to come back into the community and they have not been on methadone or Suboxone while they've been in jail. Patients who are currently on methadone or Suboxone, but they are very stable. They've had months, years of recovery, and they're on very low doses. They're tapering off. For opioid use disorder, that is the type of population that I usually reserve naltrexone or Vivitrol for, unless the patient is really eager to try to make the process work. In that case, they would need to go through detox either on their own or in a detox center and be completely off of the opiates for 1 to 2 weeks, which is really a difficult task. Between methadone and Suboxone, there's, if you want to break it down into an incredibly basic picture, I like to think in my mind with Suboxone, think of the patient who maybe is using pills, oxycodone, Percocet, maybe just using them nasally. There's no injection drug use. They've never been on methadone before. This is really their first time coming to treatment. They have been able to maintain full-time employment. They have stable housing. Whereas switching gears a little bit, methadone might be a better option for people who are actively injecting heroin and fentanyl. Their addiction has persisted over many years with multiple relapses. Maybe they have HIV, Hep C, Hep B. They're not able to maintain employment. They don't have stable housing. Like I said, this is a very basic picture that kind of breaks the two different patient profiles down. Methadone is considered a higher level of care, and that's because of the daily dosing. When someone's on methadone, they're coming into the clinic every day. They can talk to a counselor. They can ask to talk to a medical provider. The nurses are observing them. People on Suboxone, we're giving them a prescription, and we don't really know what's going on at home. So another thing to consider, and our colleagues at PCU consider this every day with every person that they admit to the methadone program, is whether they meet the federal requirements for admission to a methadone program. There's not many. Basically, the person has to have at least 1 year of opioid addiction before admission. There are exceptions to this for patients released from correctional facilities within 6 months. Pregnant patients don't need to have the full 1 year of addiction. And patients who maybe have been on methadone in the past and then they had periods of sobriety, but recently they have been sober, but they are just looking for a safety net, they can come back onto methadone. Should be for patients aged 18 and older. There can be exceptions to that too, if the patient has at least 2 documented attempts at detoxification or outpatient psychosocial treatment within 12 months. So the basis for requiring admission be limited to chronic opioid addiction, which is longer than 1 year, is that long-term exposure to opiates, including methadone, can result in a biological change in the brain, and an adaptation or alteration of some of the neurobiological function. The patient who has chronic opioid addiction, someone who's been using opioids for already over a year, likely has already had these changes take place in the brain. And by introducing them to methadone, we're not making their dependency worse or making their problem worse at all. Like patients who are young, maybe they're 16, 17, 18, wouldn't be the first step unless they've tried other options before that didn't work. You never want to take somebody who's only been using opiates for a few months and hasn't tried anything else and introduce a long-term dependence on methadone. Four big treatment considerations for every patient who's looking into MAT, and you're trying to choose the right treatment for them. Always consider the severity of their dependence. Are they using IV? How much are they using? How long have they been using for? Is there risk of divergence of the medication? In that case, you would worry about prescribing someone Suboxone. Maybe they'd be better coming into the clinic every day for an observed daily methadone dose. You also want to consider the risk of overdose. Overdose risk is increased in patients with concomitant alcohol, benzo, and other sedative use disorders. Always consider the whole precipitated withdrawal thing with Suboxone. Starting Suboxone requires that period of abstinence of withdrawal, maybe for 2 days or so. Is the patient able and willing to tolerate that period? Is this going to be possible? So like I said, there's definitive evidence for treatment matching is lacking, but there are patient characteristics that can influence your choice for medication. And that can be medical illnesses that they have, pregnancy, chronic pain, psychiatric illnesses, or comorbid substance use disorders. This chart is kind of comparing the 3 medications, methadone, bup, and naltrexone, and reasons why you would not want to prescribe them to somebody with certain medical illnesses. With methadone, you want to be cautious with people who have respiratory illness because of the risk of respiratory depression. Underlying respiratory disease exacerbates respiratory complications and leads to higher risk of death. We all know about QT prolongation. Some patients who have cardiac disease, maybe they were recently hospitalized for endocarditis, an infection of the heart. Sometimes we need approval from their cardiologist before they can start methadone. Should be cautious with severe liver disease on methadone. If the methadone cannot be processed the right way through the liver, it can build up in the system, which can cause hepatic encephalopathy or the patient to be sedated. And there are drug-drug interactions. So anybody who has HIV, taking medication for that, we do want to make sure that that does not interact with the methadone. TB meds, anticonvulsants, and we always want to be careful with benzos and other sedating medications, because if you combine them with methadone, it increases the risk for overdose. With buprenorphine, there's less risk of, not zero, but less risk of respiratory depression and overdose. Not thought to have any effects on the heart. Still be cautious with hepatic impairment. It can increase liver enzyme tests. And there's less drug-drug interactions. And naltrexone, like we said, it's not an opiate, so no respiratory depression. Not to have any direct negative effects on cardiac function. It is contraindicated in someone with acute hepatitis or severe liver failure. And it cannot be taken with opioid medication. So somebody on methadone or Suboxone cannot take naltrexone for an alcohol use disorder, for example. Methadone has been the gold standard in pregnancy since the 1970s. It's still often regarded as a standard of care. But studies have shown since then that buprenorphine is also effective. A recent meta-analysis showed that methadone is associated with higher treatment retention, but buprenorphine resulted in lower neonatal abstinence syndrome, decreased neonatal treatment time, and less morphine needed for the treatment of neonatal abstinence syndrome. ACOG and the Addiction Medicine, American Society for Addiction Medicine support methadone and buprenorphine as best practice. Currently, naltrexone is not recommended in pregnancy. Chronic pain and MAT. This is a very difficult population to treat. As we've all seen, a lot of our patients kind of get caught in this battle between needing to be on methadone for their opioid addiction and then not being able to be prescribed pain medications for pain treatment. With methadone, when it's dosed daily, once a day for addiction, it's probably not going to help someone too much for their pain. When methadone is used or prescribed for pain, it's typically prescribed a few times a day. So kind of, like I said, people kind of get stuck with taking their daily dose in the morning for their methadone clinic, and then later on in the day feeling some pain and not having really any way to treat that. In an ideal world, would be able to treat both the opioid use disorder and the chronic pain with methadone dose several times per day in the methadone maintenance treatment program or through primary care. But obviously that there are some barriers to that. Buprenorphine. Current evidence is insufficient to determine effectiveness of buprenorphine for the treatment of chronic pain. There are studies showing that buprenorphine is indicated in the treatment of pain, and many patients do feel a benefit from it. It's this kind of similar to methadone, whereas once a day daily dose will not treat their pain later in the day. Most patients need divided doses throughout the day to treat their pain in the full 24 hours. With buprenorphine, that's possible. So if you have a patient who does feel pain relief from buprenorphine, this is a great option for them because they can dose it on their own at home a few times a day, and that will hold their withdrawal symptoms, their cravings, and also their pain. Naltrexone, there's really no benefit in the treatment of pain, and it's contraindicated in patients who need to take pain medication. So someone cannot be on naltrexone for addiction and prescribed oxycodone at the same time. With psychiatric illness, some certain things to consider when you're choosing MAT is the patient's ability to manage their medications at home, their overdose risk if there's a suicide attempt, and risk of violence at the clinic. Another special population is those with concomitant substance use disorders. So our primary concern in this population is overdose with people who are using alcohol, benzos, or even cocaine. So in this population, naltrexone really is a great option if it's possible for the patient to get down, to taper their methadone or their Suboxone and transfer over to naltrexone, because we don't have to worry about that respiratory depression or that narcotic effect. We don't have to worry about overdose if the patient is combining this medication with alcohol or benzos, and it can even help treat alcohol use disorder. We will get to that really soon. So conclusions here for opioid use disorder: advise patients of the optimal approach, offer the patient choice, but keep close watch, and if needed, revise the plan, including escalate the level of care. A lot of people will just come in to intake knowing what they want. They want to be on methadone, they want to be on Suboxone. And I think it's important for patients to feel like they're part of their own treatment plan. We should offer recommendations if we really feel someone is best for methadone versus Suboxone for medical reasons. But we can always start with something like Suboxone. And I'll usually tell people, if you're still using, if we're still worried about your safety, we will have to transfer you to methadone program if that seems like that's the best level of care for you. But here at the Root Center, we have a continuum of care. We have IOP, Suboxone, methadone, so we can kind of move patients along that. And that's great. Moving on to alcohol use disorder and treatment for that. So the number one thing to consider first with alcohol use disorder is withdrawal management. If somebody is actively drinking a large amount of alcohol every day and they have had withdrawal symptoms or maybe history of seizures, we should require inpatient detoxification first to make sure that they're safe and that they're not just stopping drinking at home on their own, which can put them at risk for complications. And then we can talk about MAT. So FDA-approved treatments for alcohol use disorder are Camprol, naltrexone, and disulfiram. And off-label treatments can include things like gabapentin, Topamax, and baclofen. This goes into just a little bit about how withdrawal is treated. It's probably not too important. Benzos are the gold standard. Okay, so the 3 FDA-approved medications are naltrexone, Camprol, and Antabuse. Naltrexone is probably the most popular lately. We just went over how it's used in opioid use disorder. It's also used in alcohol use disorder. The mechanism here for alcohol use is not as well understood. It's believed to reduce the pleasurable effects of alcohol by blocking the opioid receptors, and it can reduce a person's desire to drink. I usually tell people that it can decrease their appetite for alcohol. I often hear from patients that if they do have a relapse and they open up the fridge and have a beer, that usually can stop at 1 or 2. Their appetite to keep going is not there. Camprol is a pill. Take it several times a day. It's thought to work by affecting calcium channels and modifying transmission along the glutamine pathways in the brain. This results in decreased positive reinforcement of alcohol intake. And then Antabuse, I think everyone's heard of Antabuse. Antabuse inhibits aldehyde dehydrogenase, so it prevents the metabolism of alcohol's metabolite. So drinking alcohol within 2 weeks of taking this medication can result in accumulation of acetaldehyde in the blood. This causes sweating, headache, dyspnea, flushing, palpitations, nausea, vomiting, sometimes requires trips to the emergency room. So patients who do well with this medication are typically those that are reinforced by fear. By taking this medication every day, they would be way too afraid to drink because the sickness is very, very severe. Naltrexone, Vivitrol, can reduce alcohol cravings. Additionally, it's been found to reduce drinking days in patients with alcohol use disorder and has demonstrated benefits for those who struggle with abstinence. So some of the greatest studies on naltrexone in treatment for alcohol use disorder is that it decreases the number of heavy drinking days. So for many patients, complete abstinence is very difficult, almost impossible. But if we can decrease the amount of heavy drinking days, that can have a huge impact on their health, on the health of their liver. Naltrexone blocks the euphoric effects and feelings of intoxication. It's contraindicated in severe liver disease and contraindicated in patients on opioids. So it's not an option for our patients who are on methadone or on Suboxone that also struggle with alcohol use disorder, unfortunately. Camprol, there's a heavy pill burden. It's 2 capsules 3 times a day, and sometimes that is enough to prevent a patient from wanting to take it. But it is safe and well tolerated. Some of the most common side effects are diarrhea, dizziness, itching, and it can be really effective when it's combined with naltrexone or or antabuse. Disulfiram discourages the consumption of alcohol, like I said, because people are almost too scared to drink. You take it once a day. It causes individuals to suffer from really unpleasant side effects when even trace amounts of alcohol are ingested. So even alcohol that's in food or soup, I usually tell people to stay away from mouthwash, even hand sanitizer when they're on this medication. The reaction can be pretty severe. I've had patients who need to go to the emergency room. So you have to take that into consideration with the type of patient that you're prescribing it to. It's contraindicated in patients with severe heart disease. You wouldn't want someone to take this medication and drink and have a very severe reaction and have it lead to some sort of cardiac problem. And then there are some off-label treatments for alcohol use disorder. So these are medications that don't necessarily have enough studies to prove that they are effective for alcohol cravings, but there have been case reports that they are helpful. So gabapentin is one of the most common ones that we use. Gabapentin works on the same receptors that alcohol works on. So it kind of has that in common with alcohol. They both work on the GABA receptors. Baclofen, that's a medication that's been typically used to treat muscle spasms, stiffness, kind of used in MS a lot. Recently being tested to treat alcoholism. It also works on the GABA receptors in the brain, so it can help lessen cravings and withdrawal symptoms. And Topamax. Topamax is thought to have its effect on alcohol cravings and alcohol use by also interacting with GABA and potentially decreasing the release of dopamine. And then we have our medications available to treat cocaine use disorder. None of these are FDA approved, unfortunately. We don't have any medication treatment right now that's FDA approved for cocaine use disorder or cocaine cravings. But these are the ones we've been using most often off-label at the clinic. Campril, we just went over how that is used for alcohol use disorder. Can also be used for cocaine cravings. Naltrexone, bupropion, which is Wellbutrin, Topamax, and Baclofen. So the goal with these medications when they're being prescribed off label is to try to find something that they are on label for. So Wellbutrin, consider it for people who have major depression as well as alcohol use disorder, maybe who smoke cigarettes because it's indicated for smoking cessation. Naltrexone would be a great option for somebody who also uses cocaine with alcohol or with opioids. Same thing with Campril, consider it for patients who have concomitant cocaine and alcohol use disorders. Okay, I wanted to leave some time for questions. So sorry I sped through those last few slides. Yeah, I just kind of want to open up the floor if there's any questions.
I signed in a little bit late, and I was just wondering if we were going to get a copy of these slides.
Yes, I think Darcy posts them on the SharePoint. Is that right?
Sorry, yes, I do. Sorry about that.
Thank you.
I had a quick question. You went over a lot very succinctly, so I'm not sure if I missed it or not. But in regard to somebody that wants to go from methadone to Suboxone, I believe my information was they would say if they were seeing you on a Tuesday, they would not take their dose Monday, see you Tuesday, and by the end of that Tuesday, they'd already have a prescription to take. Like, should that be an appropriate medication? If somebody, and their dose would have to be like 30 and then done type of thing. And so if somebody already has an appointment with you and she is now just wanting to, not sure if she should stop like that day, like, can they still keep that appointment with you and kind of discuss their options? And then if anything, have it be prescribed for a later date or week or another appointment?
Yeah, so there's a few different ways to do it. I think it's a little bit complicated because when transferring from methadone to Suboxone, we want to prevent that precipitated withdrawal. And the way that we usually do that is having the patient taper their dose to 30 milligrams. Once they're on 30 milligrams for a week or two, they would make a plan with me or another medical provider to prepare for the Suboxone induction. And that typically means 2 to 3 days with no methadone dose. And that can be timed out in different ways. Typically, I'll meet with someone while they're still dosing with methadone, but at the point where they're ready to go through those 2-3 days. So somebody, I'll meet with them at their intake. Maybe they dosed with methadone that morning, but tomorrow and the next day, we make a plan together for them to not dose and then take the medication on the third day at home.
Okay, that sounds good.
Yeah, if it doesn't work out like that, that's okay. Some patients will already have gone through that no dosing for 2 or 3 days and then have their appointment with me hoping to start the medication that day. And that's fine too.
Okay, I just figured I'd ask since I know your schedule's pretty tightly booked. I don't want her to lose her appointment if she just would rather talk to you first.
Yeah, that's always an option too. Sometimes I can just talk to them over the phone before the actual intake.
Okay. Thank you.
No problem. Any other questions? All right, thank you, everyone. Darcy will post the slides. Feel free to email me in the meantime with any questions or patient cases.